let's go ahead and open it up to our Q&A section. So we have quite a few questions in the chat. Some have been answered. You all were so fabulous to be answering the questions as we go. Some are very common questions, so I might go back to questions you may have answered already. But I think I might start with the question, basically like, what's the average remission time? Because I think that's a really common question. I know it was addressed a little bit, but I think everybody would be really interested in hearing from the group about that question.
So I tell patients the study that led to lenalidomide maintenance being the standard in the United States gave people a 4-year remission versus 2 years without maintenance. I think that's the bar, right? So and that's an average remission, which means some people relapse earlier and some people can stay 7 years in remission. We're hoping that with the new treatments then in the clinical trials that are showing that combined maintenance may actually be show better outcomes. Mark and Natalie, what do you tell your patients?
Yeah, I would echo that on average. So I would say that, again, if you take half of patients, you continue on the induction, the other half go on to transplant. We are going to provide on average about 4 years before the myeloma progresses with transplant and maintenance therapy, compared to just going on your continued induction and maintenance. And that difference between the two groups, between that non-transplant group and transplant group, is on average 1 to 2 years difference between progression. That said, other factors affect your chance of progressing sooner, and that's where the risk stratification between high risk, standard risk comes in. We know that high risk are at increased risk of progressing sooner.
Dr. Callender, do you want to jump in?
Yeah, no, I mean, I would agree with everything that's been said. And, but as I mentioned previously to one of the questions, we always do encounter people who do not seem to follow the path that we think they're going to be on. And so people who appear to have that 4-year predicted control, but end up having far less than that. So I think we're still struggling with trying to pick out, as Sergio is alluding to, can you use MRD to help you decide that? But I think those are all questions that we're trying to work out as we go on.
I know another common question is, how long of a response is sufficient to consider a second transplant? When would you consider it again versus not considering it again?
And maybe they could also comment on just a pre-planned tandem as well.
Yeah, I mean, for a second unplanned transplant, the one randomized study that's out there, which there are some issues with it that people argue about, but basically the timeline was 18 months from the first. Some people say 24 months at a minimum. I've even heard people say it's got to be 36 months. But I think a unplanned transplant, say if there's a relapse within a year, I think we're all assuming that by and large, and there are always exceptions, that those patients getting a second transplant in that very quick time interval are probably not going to get as much out of it, because commonly the amount of control you have for a second transplant is less. Not always, but it is on average less.
So our guidance has been that if you have more than 18 months, that we would consider a second transplant. Again, it has to do, there are various reasons to think about doing a second transplant. Some patients have, late in the course of the disease, they don't have good marrow function. So if you have stem cells in the freezer and they have active disease, you might as well give them high dose melphalan, which is an active agent given late in the course of the disease, and then support it with stem cell support. But I think the randomized trials from the Germans have shown that, you do benefit from a second transplant if your remission duration was greater than 18 months. And the longer the remission, the more the benefit.
Okay.
I agree with everything said. Typically, we will look at that 18-month to 2-year time before progression of the myeloma to consider second transplant unplanned.
Okay, well, that's a really common question, so thank you for all answering that and weighing in. There's another, this is just a very practical question from Irene. Says, is it always advisable to collect stem cells after 4 cycles, or are you looking for a certain drop in disease levels before you collect?
So I think Mark alluded to this in his discussion, that the problem is the more you wait, the less quality of stem cells you collect. So our guidance has been that you get 4 to 6 cycles of induction and collect your stem cells.
Mm-hmm.
And
Yeah.
particularly with the 4 drug regimens, it's important to collect after 4 because the DARA can affect your stem cell yield.
Mm-hmm.
And I would just add to that. I mean, if you're in a situation, say you're being treated outside of a stem cell transplant center, and it took some time to refer you to the center and get approval financially, and they're using treatment to control your disease, it's still, if you exceed that 4 to 6 cycles, it's still possible to collect stem cells. It depends on the agents that were used for induction as well. So some patients, maybe they were started on a Cytoxan regimen, may be easier than being on a Revlimid based regimen. So even if you're out, we've had patients come to us referred a little bit later for transplant consideration. They're on their 8th cycle of induction, and we'll try to move to collect stem cells quickly, and we can still be successful at collecting stem cells. If we're not successful the first time at collecting stem cells, there's also possibility we could let them recover and try again to collect the stem cells.
And I'd just like to add, I mean, there's sometimes we see patients coming in who during their initial treatment got a very strong recommendation not to consider transplant, and they'll come in 2 or 3 years down the road and say, well, is it too late? And, just my personal experience is that we had an individual who'd been on a lenalidomide trial for 16 years and actually had stem cells collected after that. So I think with our agents like plerixafor and surgery, and Mark would probably agree, there are some patients whose stem cell chemotherapy mobilization can really help in that situation. So I think you should encourage people, if they said, well, I didn't get them done, in my initial treatment, now I can't consider that at all. I don't think that's actually the case.
Mm-hmm. And I like what you said, Dr. Geralt, about, age is not a restriction. Some of these other things might not be a restriction. So let's consider it at every stage. There are some questions, several questions. I'm going to kind of group them together by David and Sam and others who are talking about genetic profiling. So how much genetic profiling can or should be done, either through gene expression profiling or NGS testing, to determine the impact of transplant or tandem transplant or other sort of strategies? What do you think? Dr. Geralt, maybe we'll start with you this time.
So risk-adapted therapy is becoming more and more utilized. And when we talk about genomic profiling or next-gen sequencing, we're really talking about trying to understand the biology of an individual's patient's myeloma. And I do tell patients, and I remind them, look, this is biology, it's not math, right? So that the fact that you might be high-risk disease by any of these categories doesn't necessarily mean that you're going to behave very, very poorly, although it does put you in a disease category that with conventional treatment, your outcome is going to be worse. I think at this time, we use it primarily to encourage patients to participate in clinical trials, but it's not, I think with this potential exception of 414 translocation and 1416 translocation and deletion 17, in which there is data to suggest that prolonged maintenance with bortezomib and lenalidomide may improve outcomes. And I think the other cytogenetic abnormality that we need to identify is 1114 translocations because they benefit from venetoclax treatment.
Mm-hmm.
And venetoclax is not approved for myeloma, but most of the time we can get it reimbursed.
We're hoping that that accelerates a little faster because it's super useful. Dr. Callender, Dr. Schroeder, do you have any comments?
I think it's very complicated, and part of it has to do with the fact that, as Sergio was alluding to, there's more and more data that sort of, yes, P53 deletion is there or not, it has to be taken into context of actually how much is there, what's coming along with it. And then what also makes it more complicated is we're pretty confident now that people gain different alterations as they go through treatment. And so Some of these changes seem to persist, but there are other new ones that show up. And I think we're just sort of at the very tip of learning how to integrate all of this into really actual decision making.
Yeah, and I would just highlight, yeah, the standard currently for anybody newly diagnosed or at the time of relapse is to perform that panel for FISH testing. That's going to show high level. I think what the question's getting at is also if you have specific mutations in genes, and there are clinical studies open now that are trying to guide treatment to, they're called basket studies. So they do sequencing of the myeloma, and they find specific mutations in genes that we actually have available drugs, and we add that on to a backbone of treatment for myeloma. And that would be a completely acceptable study, I think, to participate in for somebody that has the myeloma come back, because we know, as Dr. Callender pointed out, that the myeloma changes over time in treatment. So just because you had a certain profile up front, it needs to be repeated. There could be additional mutations that are acquired in the myeloma, and these are novel concepts that should be studied in the context of a clinical trial.
Okay. I'm going to ask another question. This one's specific, but I want to ask it more broadly. Betty's wondering if she's at higher risk during transplant because she doesn't have a spleen. But could you cover patients who are just more at risk in general? Dr. Drollet, you mentioned it's fitness, not age. But what other comorbidities are the most concerning for you when you think about stem cell transplant?
So I think some of the myths we want to dispel is that, oh, I am on dialysis, I can't get high dose melphalan. That's not the case. We can transplant patients. We can give patients on dialysis high dose melphalan. Although most of them will not recover kidney function, there is a fraction of patients with myeloma that after high dose melphalan will recover some degree of kidney function and even come off dialysis. The other one that's common is, oh, I mean, I have diabetes or I have cardiac disease. So we do score comorbidities, and in patients, as long as their comorbidities are well controlled and they have a good performance status, we think these patients are transplant eligible. Many times we do reduce the dose of melphalan to account for those comorbidities. And then obviously, I think another important factor is social support and caregiver support, which determines, I mean, generally speaking, if you have a caregiver, we do consider outpatient transplant. We think recovery is quicker when we do an outpatient transplant. If you don't have a caregiver, we admit you to the hospital. And then most people are back to normal within 60 days. So I think the comorbidity issue is one that has to be addressed on an individual basis.
Okay. And we have oh, go ahead.
Yeah, I just like to put in a quick plug for vaccinations. I think that there was a recent study done where they were looking at vaccination rates in myeloma patients around the world. And the US had the highest rate, but it was only 40% of patients. And this was just for looking simply at flu vaccines and pneumococcal vaccines. And we know pneumococcal sepsis, not only in splenectomized people, but in myeloma is really one of our #1 bacterial infections. So we are really bad at using something that's cheap relatively and effective. And we should be definitely promoting that more.
And patients can be vaccinated on lenalidomide maintenance and they'll respond to the vaccine.
Okay, good protection, especially we want to think about that, especially during this time where we don't, every sniffle or, you think is COVID.
Right.
Yeah, in addition, I would add in terms of, and I glossed over this in my talk about what we do peri-transplant, but when you come to a transplant center for evaluation, it's not just kind of a gestalt feel of the transplant physician, whether you're fit or not. It's also going to be some assessment. They're going to assess your cardiac function with the echocardiogram. They're going to check your lung function with pulmonary function tests. And we know that patients who have compromised cardiac function are going to have harder time to get through the transplant or potentially compromised lung function. So that may determine, if it just not by just looking at you, whether you're a candidate for transplant or not. And that said, for this type of transplant, for auto transplant, the toxicities are really, it's upfront. It's an upfront toxicity risk. When your counts are low, when you don't have the white cells there to fight infections, can you compensate for when bacteria gets in your bloodstream and causes infection? And that's the risk of mortality of this type of transplant, is when your counts are low, Are you in the right setting to support you? Are you getting the right antibiotics and support? Is your heart and lungs strong enough to be considered for transplant?
Mhm. And I like what was said earlier about, intensive therapy versus kind of continuous therapy. And I opted for a tandem transplant when I was first diagnosed because for that very reason, and it's, for me, I want to kind of transition to a tandem transplant question, but it turned out to be a great choice for me. And it kind of felt like all one therapy because they were so close together. There's a question about tandem transplant specifically, and all of you have touched on it a little bit, but I want to address it about what's the % benefit of high-risk myeloma patient to do a single versus tandem. Do you have any thoughts on when it's best used and in what circumstance?
Well, I mean, I would just highlight from the data that I reviewed from the randomized study of Dr. Geralt that looked at patients who received tandem transplant versus just going on to maintenance treatment. And there was, at 5 years after the transplant, those with high-risk myeloma who underwent tandem transplant, that means first transplant and then around day 100 after the first transplant, go on to the second transplant. Those that underwent tandem transplant with high-risk disease had about a 10% improvement in whether they progressed at 5 years or not. So that's the absolute difference. So it's potentially a small difference. It's going to potentially prolong the time before the myeloma progresses in that study in particular at 5 years.
Mm-hmm. And Dr. Gerald, do you want to comment on that?
So I think, this is a very difficult question, and I agree with Mark. Look, for patients with high-risk disease, currently, of all the strategies that have been published, the tandem transplants has been associated with probably the best outcome. Now, one of the problems is that particularly in the United States, for individual patients to undergo tandem transplants and be out of work or it becomes logistically not easy. Mm-hmm. So you have to have alternatives to provide patients. I generally think that one of the things that we collect enough cells for for 2 transplants, and I don't think we're doing enough salvage transplants in our patient population. And actually, unfortunately, many patients have actually been in a circumstance where their counts have been very poor, and they haven't utilized the source of stem cells that they have in the freezer, which can help them recover their counts. But I think I offer patients with high-risk disease to consider tandem transplant as a possibility. Many of them have refused, and then either we have a clinical trial for them and then looking at post-transplant consolidation with new drugs or with more intense regimens, or if they don't want to participate in a clinical trial, I will give them a combination of bortezomib and lenalidomide, and if possible, the CD38 antibody. Mm-hmm.
Okay, there's so many new therapies coming into play. It's really tough. Like when I was diagnosed, that was back in 2010. So, I mean, there was nothing that was, quote, curative. And I was young. So my approach was kind of like, go for it. I'm going to get it now or later.
You still are young, Jenny.
I hope so. I don't feel as young as I was. But I've had a really good response. So it was a great option for me. Okay, we have questions about some induction therapy. So when induction, and Dr. Kreese, you're welcome to join in as well. And we might not all be able to answer the same questions. So I might jump around a little bit. But if you feel so compelled, please jump in and answer, but we have a lot of questions. So we have 75 questions now. Okay, Rebecca is asking if an initial induction VRD was not that successful in now Darzalex and Kyprolis, is somebody like that still a candidate for a stem cell transplant? But I want to extend this question too. How deep do you need to go? I know you talked about this a little bit already, but we get that question all the time. Like, should I keep treating, and then wait for this long-term durable response before we go to stem cell transplant or not?
I would say no. I mean, I think Sergio very, very clearly, I thought, laid out a very good case. I think people are usually nowadays, because we have more choices, very tempted to do another regimen, but I don't think you want to waste somebody's time doing regimen after regimen when we really do have good data that melphalan tends to be sort of the great equalizer, if you will. And I think that we do want to take those patients to treatment.
Mhm.
Yeah, I agree as well. And I mean, I saw that there were some questions about, well, what if the product's contaminated with cells from myeloma? And as Dr. Drell pointed out, that there's not any data that in that situation that we can select the products better, or that makes a difference in terms of outcomes. And somebody that doesn't respond to our standard treatments should still be considered for melphalan. It's a different agent, works differently. As we saw in the case that Zach presented, patients can have good responses to melphalan, even though they haven't responded to what we think are the best agents out there.
Mhm.
And it also begs the question, in somebody who seems to be refractory up front and maybe has high-risk disease, who then gets treated with combination chemo salvage or high-dose melphalan, as Dr. Geralt pointed out, maybe you eliminate some of those resistant clones and the disease changes over time. And maybe those patients who weren't initially very responsive to therapy may subsequently post-transplant benefit from those novel agents that they weren't benefiting from before. So it's a good opportunity to kind of reset the disease and see if maybe you can change the biology of the disease in a way that allows you to use some therapies that might otherwise have not been effective.
So Zach, I think this issue of clonal diversity is very important. I
Yeah.
mean, myeloma clones are like your children, right? They might come from the same father and mother, but one of them plays the piano, the other one plays soccer, and the other one is tone deaf. So, and yet they come from the same father and mother. So myeloma cells, actually those clonal diversity speaks to why we can re-challenge patients with myeloma to drugs that they were quote unquote resistant to before, and they will still respond. And I think also, for when we talk about high dose melphalan and whether the graft is contaminated or not, we need to think about it in this context. High dose, if you have 1 million myeloma cells in your body and high dose melphalan eliminates 900,000, even if I give you 10,000 back in the graft, you're still 10 times better than you were in the beginning. And there were studies with purgings that were actually very effective in getting rid of all the myeloma cells in the graft, but it was associated with a much slower immune reconstitution, and it didn't result in improved outcome.
Mhm. Can I ask a question too about you talked about now, Dr. Callender, how CAR-T or something like that might eventually replace stem cell transplant. But if transplant is being used to really reduce a tumor burden and is very effective to do that, I know some studies are being thought about, or maybe they're already in place, to follow up transplant with CAR-T therapy that doesn't work so well if you have super high tumor burden. I think you should all speak to that.
Yeah, I mean, I think those are absolutely research questions that are under investigation right now. Is, what do we do with these therapies? Could you omit transplant, or should it be a companion to transplant to use these immunotherapies? And I think as Sergio was talking about the tandem issue, it still is a big chunk of time to ask people to devote to a transplant. 3 months, probably 6 months if it's a tandem. And, I think we here, I believe everybody on this panel feel very comfortable recommending a transplant, but I think we're also know that things evolve, and, transplants may not be here forever. And I think there's still a reason to say, let's try to make them better. Let's try to see whether we can omit them. And, all of the issues that Sergio brought up about sort of innovations, I think those are all great that they're happening. And again, clinical trials.
Yeah, I agree. We always recommend patients trying to think about clinical trials. Newly diagnosed smoldering myeloma, relapsed myeloma. I mean, every time, think about clinical trials, because there are so many. And please don't wait, because if you wait, you may not have that as an option. So, Dr. Dralt, do you want to follow up with that idea?
So I think, look, we are now at a time where we have more classes of drug for myeloma than we've ever had in 2 decades.
Yeah.
The challenge is, how do we sequence them and how do we use them the best? And I think the goals of all of us are the same. And we want to give everybody the longest life with the best quality of life with the minimum treatment necessary. And one of the patients said it up front, that your best chance is to get the best treatment up front to get that long first remission. And I think that, we have to learn from the other diseases that we cured. I mean, we cured Hodgkin's disease, we cured acute lymphoblastic leukemia, we've actually, and we do still cure a very small fraction of patients with myeloma, and we cure it with induction, consolidation, and maintenance. And I think before we throw away one of the most important components, which is consolidation, we need to do the clinical trials to say it can be replaced by CAR T, it can be replaced by this, or it can be replaced by the other. So I think we have ways that we're going to make high-dose melphalan better. It may be that something else will replace it, and that's great. I mean, if we could reduce the burden of treatment for patients, that would be great.
Mm-hmm. I always remember hearing you say, like, melphalan's the single most effective drug. That was from years ago.
Yeah.
So yeah, I think it'll be interesting to see how all these things play together. So fascinating. Okay, there's a question. If someone is early diagnosed with no bone tumors, this is a question from Carl, 15% of plasma cells with amyloidosis, how do you treat amyloidosis in relationship to stem cell transplant? This is an area I don't know anything about, so that might be a dumb question. But.
Yes, I would, I mean, for amyloidosis, it is potentially a different treatment. So we really didn't focus on that in this discussion at all. But amyloidosis, you need to look for deposition of the amyloid protein within the organs, such as the liver, the heart. Oftentimes we'll get biopsies of the skin. The standard induction outside of clinical trials would be a combination of drugs like Cytoxan, Velcade, dexamethasone, and those patients with amyloidosis would be considered for transplant. There are patients who present kind of with both things at once. They have amyloid deposits in the heart or the kidneys, and then they have increased plasma cells, and they might have evidence of both diseases. Those are patients that we consider with our standard induction in transplant strategy. The risk of transplant in somebody with amyloidosis is increased if they have substantial heart involvement with amyloidosis. So we'd modify regimens for collecting the stem cells in those patients to decrease the toxicity of stem cell collection in patients with amyloidosis. But they should still be considered for stem cell transplant.
Mm-hmm. Okay, great. A question also from Tammy is kind of an interesting situation. You all talked about Revlimid maintenance. I think it's well known that as maintenance therapy and consolidation after transplant is important. For a higher risk patient, she's younger, has 414 in the UK, so more difficult to get drugs, right? And just wants to know if she should be thinking about a dual maintenance therapy. And some of you have addressed this a little bit already, but Revlimid with proteasome inhibitor, do you think about that for higher risk patients, and which ones?
I think we do. In that space, largely though, still on single institution studies. There's been some very influential publications using maintenance with Velcade, Revlimid, and actually even some dexamethasone that has not been randomized to show that is clearly superior. And I think it was Mark was showing the MRC study showing that every risk group benefits from lenalidomide, whether it's high risk or not, maybe just not as much. But I think, in the US, yes, a lot of times people are asked to take Velcade or perhaps Ixazomib with Revlimid. I think people feel more comfortable with that, but I think we still don't have phase 3 data saying that that's the right thing to do.
And I would just chime in too. I think one thing that we've all kind of tried to touch on in some of these presentations is that even if you're on Revlimid and maintenance and the disease begins to show signs of more activity, the good news is that we have a lot of salvage regimens. We have a lot of different treatment options that you can then proceed to. So I think that, as Dr. Callender said, in the absence of solid randomized data to suggest one over the other in a particular risk group post-transplant, it's reasonable to do lenalidomide and then know that you have other options if that fails to work or stops working.
Okay, this is a very common question, and one you've already addressed really in talking about the importance of stem cell transplant, but we still get it all the time. Like, do you need it, if I did so well in my induction therapy, why am I still, and I'm totally in remission, then why am I still considering a stem cell transplant? We get that all the time. I'm sure you do.
You got to show that picture of the iceberg that Dr. Geralt had.
Mm-hmm. Yeah.
Again, I think a lot of this depends on an individual patient's circumstances. If you're 78, you had stage 1 disease, and you had a complete remission to the induction, it makes sense to get your cells collected and maybe delay your transplant. But if you're 58 and you had stage 3 disease, even if you had complete remission, you definitely should think about getting a transplant, maybe a tandem, and then going on some form of combined maintenance treatment because you have high-risk disease. So I do think that, and I tell patients, make it hard for us. Make it hard. Get a complete remission, whatever not. I actually tell patients, look, even if you're MRD negative CR, I think the high-dose melphalan will get you into a deeper remission, and that means a longer remission duration.
Mm-hmm. Yeah. Okay. Well, it's just emphasis, I think, that I was looking for. Okay. Susan has a question. Talking about induction therapy. I know you have all said that RVD is kind of the most common. When do you use Kyprolis in induction instead? And are there genetic reasons for doing that, or what do you think?
This highlights a recent publication. Maybe Dr. Schroeder or one of the other faculty want to weigh in about a recent publication comparing head-to-head VRD with KRD. And so this is one of those great questions which we have a really great answer to now. So
yeah, I mean, as Zach alluded to, and Dr. Callender also highlighted, and I tried to address in my presentation, yes, risk stratifying based on standard risk or high risk disease is what we recommend. High risk disease means RISS stage 3, or if you had cytogenetic abnormalities in 414, 1416, or 17p deletion. In those patients, the high-risk patients were not included in the study that Zach alludes to. Those are standard risk patients randomized to either Revlimid Velcade dexamethasone or carfilzomib Revlimid, or carfilzomib Velcade dexa, or carfilzomib Revlimid dexamethasone, sorry. And there was no added benefit in progression-free survival between the groups. So somebody standard risk, Revlimid Velcade dexamethasone would be standard. Somebody high risk, we'd consider carfilzomib Revlimid dexamethasone, potentially in both of those situations, even a 4-drug induction possibly on study.
I think the only other thing I would say is if somebody came in with, say, either a couple of situations like bad neuropathy from some other reason, like maybe diabetes, we might go straight to carfilzomib. Or if they have a very significant cardiac history, we might stay far away from carfilzomib and say, yeah, that's just not a drug for you.
Mm-hmm. Okay, Eloise has a question. What are the factors you use to determine when to use a second transplant versus using other myeloma types of combinations or therapies?
I think we've addressed the duration of first remission and exposure to prior drugs. So, I mean, we now, with patients getting 4-drug inductions and maybe 2-drug maintenance, once the disease recurs, it does give you the idea that you have to expose them to something different. We're doing a lot of second transplants for patients who have suboptimal response to salvage to be able to get them into a deeper remission and then qualify them for some investigational protocols for maintenance.
Mm-hmm. Okay. I have a question too about vaccinations. You talked about vaccinations during the stem cell transplant process to protect against infection. What are the suggestions for vaccination of childhood diseases post-transplant?
There are very clear recommendations from the TCT, just in terms of the American Association for Cellular Therapy and Transplant. Those are easily accessible. They're on a website. I mean, basically, the principle is that, yes, we do try to revaccinate people. You can check to see if titers are preserved, and then some people will say they're probably not necessary. But again, I think we really under-vaccinate. There is some fascinating data that's starting to come out that for people who don't either get a titer after a vaccine or lose them and don't regain them, that is somehow associated with a less robust response or less survival actually in myeloma. So I do think that people should ask their physicians to just use that as a reference. It's very clear. And that's, I think most places use that standard.
Okay.
Yeah, we would do the same. The only thing I would add to that is that I always advise also that patients, flu vaccine, yes, annually. Everybody around you caring for you should get the flu vaccine to provide some immunity around you against infections that we can prevent.
Yeah, good point. Okay, great point. Marcia has a good question. Does the information that you're talking about for myeloma also apply for plasma cell leukemia? Either maybe you want to address it primary or secondary plasma cell leukemia.
So plasma cell leukemia is probably the highest risk myeloma when it presents as a primary. So that's your presentation. I think many of us will treat it very aggressively with combination chemotherapy, then 1 or 2 transplants in a young patient. The second one might be an allogeneic transplant, and then some form of post-transplant consolidation and immunotherapy. We have, again, we're looking at doing CAR T cells as consolidation. These are very challenging patients. Secondary plasma cell leukemia, which is plasma cell leukemia that evolves later on in the course of the disease, is an extremely challenging situation. There are really no good treatments for this. Our recommendation is participate in a clinical trial. Unfortunately, most clinical trials exclude plasma cell leukemia. We're hoping that with the advent of CAR T cells, we can then start looking at, commercial CAR T cells will allow plasma cell leukemia, that we can then start developing trials for these patients. They're few and far between, thankfully. So doing clinical trials is challenging in the patient population. But for primary, we think aggressive therapy is effective. For secondary, very few options. I'd like to hear what Mark and Natalie think.
Mm-hmm.
Yeah, no, I would agree. And one of the I'm younger, so one of my frustrations is that there aren't a lot of trials that include these patients for options for treatment. So we do need to invest more in clinical trials for these otherwise rare populations of patients with plasma cell leukemia, but an intensive induction, some consolidation, considering allo for young people who are able to get disease control. That's the problem, is the disease doesn't stay under control that quickly, especially the primary plasma cell leukemia or the secondary plasma cell leukemia. So I would take a similar approach.
Yeah, and I think just what both Sergio and Mark are saying is that for plasma cell leukemia, often when it's primary, it actually will respond just as well as anything else. It's just keeping it there. And so I think Sergio is saying, you sort of batten down the hatches thinking you're going to have to use everything you've got. I think a lot of people would take that approach. And again, we just are barred from trying to get these people on trials, even when newly diagnosed. And actually that's really a problem, because basically we're just treating people based on expert opinion.
Mm-hmm. Okay. Yeah, that's a tough one. I know. A follow-up question. So melphalan, you kind of mentioned melphalan, Dr. Drell, about that it's kind of a different form, but it's not necessarily to replace transplant, right? Do you want to just expand on that?
So,
about how that might be used?
There's two, we're going to say there's 2 formulations of melphalan. One is the one that it was done in a non-transplant trial that has been, proposed for approval by the FDA in multiply refractory patients. So same place where selinexor is. And then a modified version of that same drug that will be used in transplant studies that are not yet ready to be done, that are currently being planned. And it's there to replace. So melphalan is melphalan that has a phenylalanine placed on its structure. And what it does is it gets incorporated into myeloma cells more frequently than it does into normal cells. So think about it as a way of getting more bang for your buck, or more melphalan into the myeloma cell than into normal cells. So you theoretically will be able to, with the same dose of drug, eliminate more myeloma cells than you do with regular melphalan.
Okay. Well, we're looking forward to that. Rosalind had a question about stem cell transplant when you're looking at extramedullary patients, or patients, maybe somebody wants to describe what that is, and what you typically see in your clinics?
Well, extramedullary refers to medullary is just sort of the medical term for bone marrow, if you will, in this case. And so it's myeloma that occurs outside of the bone marrow. And it's been a recognized entity, but I think what we're realizing more and more that we use, as we're using advanced imaging, that it's actually not that uncommon. And in some studies, at least 10% of people walking in the door with a new diagnosis of myeloma have it. We just didn't recognize it before. There are patients who seem primarily to have just that and not bone marrow involvement, and they may really be sort of a different entity and in some cases almost behave more like a lymphoma in terms of how they present. I don't know that anybody feels that we have a strategy primarily for EMD, extramedullary disease. It's pretty much what we have outlined. Sometimes if there's a individual very large mass, people will use localized radiation therapy for it. But I think there's actually some fascinating data that perhaps the myeloma genetics, going back to that question about genome typing and sequencing, that there may actually be different characteristics of the myeloma cells in those that decide to form a deposit outside of bone marrow versus those that are actually in the bone marrow. But I think we just really don't understand that very well yet.
Mm-hmm. Okay. I want to ask one question that was emailed in. The patients, I know acyclovir or valacyclovir is being used post-transplant. The doctor said that it can potentially affect renal function, which the patient's concerned about. But how long do you take acyclovir or these other supportive medications for after transplant or during transplant? Dr. Schroeder, do you want to take
Yeah,
that?
sure, I can answer. So typically we'll continue, so that's a prophylactic antiviral medicine to prevent reactivation of herpes simplex virus, so cold sores. Typically we'll continue that through 3 or 6 months post-transplant before it's stopped.
And if there's a concern about renal function, do you space it out at all?
So when we use these medicines or any treatment for somebody with myeloma, we are monitoring renal function. These are otherwise fairly safe prophylactic medicines that can prevent an otherwise very painful complication of being on immunosuppressive chemotherapy for your cancer. So the risk of kidney problems on Valtrex or acyclovir is still relatively low, and you're going to be monitored for it when on it.
And, along with the simplex, varicella is a huge problem, the chickenpox virus, and that's another huge reason we keep people on antiviral agents. We know that chickenpox can become active as shingles post-transplant, but also for people who are receiving Velcade or carfilzomib, that seems to be a particular risk, and even Revlimid maintenance. So I think each institution has a little bit of a different strategy. We actually keep people on antiviral therapy for a year post-transplant. That's been our standard. And then longer, depending if they're on Velcade maintenance, for example. I think one of the things that we don't know yet as a group, and I'd love to hear what all of our panelists say, now that we have the Shingrix vaccine, is anybody feeling like if you've had the Shingrix vaccine and a patient is receiving either Velcade or carfilzomib, you feel comfortable enough not having them on antiviral therapy?
So we've been doing that. If you're on maintenance lenalidomide and you get the Shingrix vaccine, you can come off your acyclovir. But if you go on bortezomib, you have to go back on it, even if you have titers.
Okay.
Yeah, and I would just add that we do vaccinate Shingrix post-transplant for patients now. Would still continue that strategy of the acyclovir Valtrex, like I outlined, for 3 to 6 months, considering, if they're higher risk for reactivation, continuing on if they're on proteasome inhibitors.
Mm-hmm. Okay, great. Well, we can't talk about stem cell transplant without addressing the COVID situation. I know you all are in different locations, but Dr. Drault, you've probably been hardest hit. I don't know how it's been for Dr. Callender, Dr. Schroeder in your area.
In March, when COVID hit, because of concerns of, personal protective equipment, concerns that we would become a surge hospital, we actually continued to collect myeloma patients, but we deferred all autologous transplant.
Mhm.
In mid-May, early June, we reactivated, and we delayed about 30 myeloma patients, which we're now, getting them all through. We just published the experience with transplant patients who were exposed to COVID or who had COVID. Many of them recovered without incident, but there were some who got into trouble, and particularly those that required to go on the vent. But it's very hard to predict. And I use the anecdote of one of my patients who actually was, 2 months post a second transplant for acute leukemia. Her husband got COVID. He ended up in the ICU for 6 months. She had 3 days of fever.
Wow.
So it really, there's some individual differences that we don't understand. Obviously, I think the most important thing is to protect yourself, mask and social distancing.
Mm-hmm.
Right. I can't stress that enough. I think I think what unfortunately didn't happen in March is just somebody standing up and saying, let's all wear masks, let's all wash our hands, let's all social distance. That's going to help in the long run. We're in a situation in Wisconsin where I think we were sort of saying, that's everybody else's problem. We're doing okay. We have our own big surge going on right now. But I think that's what makes this, I think anybody who's a healthcare professional realizes that's what's so concerning about COVID is, yes, you can find the individual who did great, who you would have thought shouldn't have any problems in the world. And then there's a 28-year-old physician in Houston who has no other problems, who's dead. And so I think, we just don't know enough about how this virus behaves and who it picks out to just say, oh, don't worry about it. I think, we are still right in the midst of this. It's obviously the numbers are going up, not down, and we all need to do our part to try to keep it as contained as possible.
Mm-hmm.
Yeah, I would just say at our center, similar to Dr. Geralt, we did end up stopping performing transplants up front with the pandemic. For any patient out there, we talked about that the cells are cryopreserved. So you have time to use those cells. You don't have to rush to transplant. So in addition to pausing transplants, we've now resumed. We've implemented additional screening procedures for patients. So our patients are also going to be swabbed prior to coming in for transplant. We've restricted visitors in the transplant unit and restricted to just having one patient being able to visit with the patient and care for them during transplant. So we've made modifications to make it safer for patients. I always highlight to patients that, it is an elective procedure. If you're feeling sick, if you're feeling ill, don't come in for the transplant day. Call us, let us know, because the worst thing that you want to do is to get the dose of chemotherapy and have a bad outcome after transplant.
Mm-hmm. Okay, I just have 2 more questions. One is about just risk of, I know secondary cancers can happen because of like long-term Revlimid, or is there an increased risk using transplant or no, and what is that? And then the last question would be about smoldering myeloma.
So was the question was secondary cancers?
Yes. Uh-huh.
Okay. So I tried to address that a little bit in my discussion, and this was evaluated by the CTN randomized study. There was not an increased risk of secondary cancers of patients who were continued on Revlimid maintenance, whether they stopped Revlimid or they continued on, not an increased risk. The risk of autologous stem cell transplant is there's a less than 1% chance of inducing another malignancy such as a leukemia related to the exposure to that chemotherapy. That risk is constant after transplant. Most of those secondary cancers arise after transplant within the first 5 years.
Mm-hmm.
But it doesn't appear that our maintenance strategies and continuing maintenance after transplant alters the risk for secondary primary malignancy.
Okay. And last question. In what context could a smoldering myeloma patient consider a stem cell transplant? I know there are some trials for smoldering, usually high-risk smoldering myeloma patients that are, let's try 1 or 2 therapies together. Let's try immunotherapies, let's try vaccines or other type of modalities, and then let's try to just treat them as if they were a myeloma patient and see if you can go for the cure. What's your perspective on smoldering myeloma?
That's a difficult one. I mean, I think smoldering myeloma patients should seriously consider participating in clinical trials. And the clinical trials there's a clinical trial in Spain where actually these patients are getting transplanted. And there's a clinical trial here that high risk, and again, as Mark was alluding to, has to risk stratify. So really high risk smoldering myeloma should consider going on a clinical trial or going on lenalidomide, for which there is data now to suggest that there's a delay in progression. But anybody else, I think, and I still think the jury's not out about whether those patients are going to live longer. They're just going to be treated for a longer period of time. And I do think that still patients with smoldering myeloma should consider participating in a clinical trial.
Mm-hmm.
Yeah, I agree. Clinical trials, I would not, off of the clinical trial, consider transplant in somebody with smoldering myeloma.
Okay, great. Dr. Callender had an emergency and had to go. But I kind of want to end with a comment from Edwin, and I think this is reflected by everybody who's participated in this first session about stem cell transplant. He just said, excellent presentations that has allowed me to make the right decision about stem cell transplant. Not an easy choice, but the right one for me. And in summary, all these seminars are an excellent informational tool. Thank you for your time. And I would just say, this is why we always suggest seeing a myeloma specialist. So if you're being treated by a local oncologist, I think it's fine, but you need to, when you're making these important decisions about what to do, please consult with a myeloma specialist. And I know telemedicine visits are more common now, so try them. Like if you can get a telehealth visit with an expert like this, Dr. Drell and Dr. Schroeder and Dr. Kreese, it's just so important to get the experience. It's so nuanced. There's so many different treatment combinations. It's just so important. So I just thank you so much for participating today.